Pervasive developmental disorders. Promo. What is the difference between pervasive developmental disorder and autism? Second one is, what is Skinner syndrome? Third one is hand bringing in seen in. Fourth one is the little professor syndrome is. Fifth one is, what is Heller's disease? Pervasive means is especially of an unwelcome influence or physical efforts spreading widely throughout an area or a group of people. Pervasive development disorder characterized by impaired reciprocal social interactions, aberrant language development, restricted behavioral repertoire, typically emerge before the age of 3 years. DSM-4-TR include 5 pervasive developmental disorder: autistic disorder, Rett disorder, childhood disintegrative disorder, Asperger's disorder, pervasive development disorder, not otherwise specified. DSM-5 has consolidated autistic disorder, Asperger disorder, and PDD into autism spectrum disorder. Diagnostic criteria for DSM-5 is persistent deficit in social communication and social interaction across multiple contexts as manifest by the following currently or by history. First one is deficit in social emotional reciprocity. Second one is deficit in non-verbal communicative behaviors used for social interaction. In deficit in social emotional reciprocity ranging from abnormal social approach and failure of normal back and forth conversation. In deficit in non-verbal communicative behavior used for social interaction include ranging, for example, from poorly integrated verbal and non-verbal communication to abnormalities in eye contact and body language. Third one is deficit in developing and maintaining an underlying relationship, ranging, for example, from difficulty adjusting behavior or suit various social contexts. Specify current severity. Severity is based on social communication, impairment, and restricted repetitive pattern of behavior. Restricted repetitive pattern of behavior, interests, or activities as manifest by at least 2 of the following currently or by history. First one is stereotype or repetitive motor movement. Second one is instance or on sameness, inflexible adherence to routine or ritualist pattern or verbal non-verbal behavior. Third one is highly restricted fixated interests that are abnormal in intensity or focus. Fourth one is hyper or hyporeactivity to sensory input or unusual interest in sensory aspect of environment. Specify current severity. Severity is based on social communication, impairments, and restricted repeated pattern of behavior. Symptoms must be present in the early developmental period, but may not become manifest until social demand exceed limited capacities or may be masked by learned strategies in later life. D is symptoms cause clinically significant impairment in social, occupational, or other important area of current functioning. E is these disturbances are not better explained in intellectual disability or global developmental delay. Specify with or without accompanying intellectual or with or without accompanying language impairment associated with a known medical or genetic condition or environmental factor associated with another neurodevelopmental, mental or behavioral disorder with catatonia. So now we will discuss the autistic disorder. इसको early infantile autism, childhood autism, or Kenner disease we can say. Characteristic features of are qualitative impairment in social interaction. Second one is impairment in communication. Third one is restricted, repetitive, and stereotype pattern of behavior or interest. History. In 1867, Henry Maudsley said it is psychosis. In 1943, Leo Kanner uh, told these symptoms as autistic disturbance of affective contact, coined the term infantile autism. Autos means in Greek is self, and lismos means is state. Kanner's, how he is described, Kanner's description is autistic loneliness, failure to assume an anticipatory posture, delayed or deviant language development with echolalia and pronominal reversal, U for I, monotonous repetition of noise or vulgar utterance, limited range of spontaneous activities, stereotypes, and mannerisms. Anxious, obsessive desire for maintenance, thinness, and dread to change, poor eye contact, abnormal relationship with persons, preference for picture and inanimate objects. Before 1980s, often misdiagnosed as schizophrenia. Uh, Childhood autism, social dysfunction, difficulty in maintaining social contact or other non-verbal social cues. They are not able to exclude social cues. Abnormalities in communication are also observed among individuals who talk. Various unusual feature of language are observed, like echolalia and pronominal reversal. Literal resistance to change, stereotype, and repeated motor mannerism, strict adherence to non-functional routine, interest in non-functional part of object. Epidemiology, 8 cases per 10,000 children, 2 to 30, onset before 3 years, 4 to 5 times more frequent in boys, girls, uh, severe MR. No MR is intellectual disability. Now it is called intellectual disability. No association between autistic disorder and socioeconomic status. Etiopathogenesis is first one is genetic factor, 50 to 100 times increased rate in siblings, increased risk of other developmental disorder. Linkage analysis study shows demonstrated region of chromosome 7 to 4, 15, 19, 16, and 17. Concordance rate monozygotic twins 36 to 96%, dizygotic twins 0 to 27%. It may be associated with fragile X syndrome, tuberous sclerosis. Biological factor associated with intellectual disability 70% and seizure disorder. 4 to 32% have grand mal seizures. 20 to 25% shows ventricular enlargement in CT. 10 to 83% shows EEG abnormalities associated with neurological condition like congenital rubella, phenylketonuria, tuberous sclerosis. Congenital physical anomalies may be present. Third one is immunological factors. Immunological incompatibility, maternal antibodies against fetal lymphocytes, the tissue response and their effect appear confined to the brain and indicate an intact blood-brain barrier. Fourth one is perinatal factor. Maternal bleeding in the first trimester, meconium in the amniotic fluid have been reported. Higher rates of respiratory distress syndrome and anemia in the neonatal period, long gestational period, high birth weight. Neuroanatomical factors. There are some neuroanatomical factors. Traditionally, autism was considered as a disease of because of some abnormalities in cortex, enlargement of gray and white matter cerebral volume. There may be increased rate of SC growth at about 1 year of age, increased total brain volume, occipital, temporal, and parietal lobe may be affected. Biochemical factor, high plasma serotonin level is found in one-third of the patient. High concentration of homovalenic acid. Symptom severity decrease as the ratio of 5-HIAA to hemovalenic acid in CSF increases. Psychological and family factors exacerbated response to stressor. And these are the some clinical features. Also, first one is physical characteristics. High rate of minor physical anomalies may be there. A lack of lateralization remain ambidextrous. Abnormal dermatoglyphics, fingerprints, disturb neuroectodermal development. Behavioral characteristic is qualitative impairment in social interaction, lack of social smile, anticipatory posture for being picked up by an adult, difficulties in responding to others' interest, emotion, or feeling, impaired but not usually totally absent, attachment behavior. Cannot make attribution about the motivation or intention of other and thus cannot develop empathy. Disturbance in communication, language deviance and delay, significant difficulty in putting meaningful sentences together, even when they have large vocabularies. Conversations impart information without providing a sense of acknowledging how the other person is responding. Patterns of babbling may be minimal or abnormal. Words and even entire sentences may drop in and out of child's vocabularies. Typically exhibit echolalia or stereotype phrases that seems out of context. Pronoun reversal common. Stereotype behavior, absence of spontaneous exploratory play, lack of imitative play, ritualistic and compulsive phenomena, attachment to inanimated objects, movement abnormalities, especially with intellectual disability, stereotypies, mannerism, and grimacing, resistance to transition or change. Instability of mood and affect may be there. E is response to sensory stimuli, over response to some stimuli, and under response to some other stimuli, sound and pain. And they enjoy music, enjoy vestibular stimulation, spinning, swinging, etc. Associated behavioral disturbance may be there, hyperkinesia, aggression, and temper tantrum, self-injurious behavior like banging head, biting, stretching, etc. may be there. Poor attention span, poor ability to focus on a task, insomnia, feeding, and eating problem, aneurysms. Associated physical illness, higher incidence of URI and minor infection like GI symptom, excessive burping, constipation, febrile seizures, allergies. Intellectual functioning, 70 to 75%, there may be intellectual disability, unusual or precocious cognitive or visuomotor abilities, hyperlexia. Course and prognosis, lifelong disorder with guarded prognosis. IQ is sometimes more than 70. Those who are use communicative language by 5 to 7 years have good prognosis. Symptom related to ritualistic and repetitive behavior, poor in improvement. Adult outcome, two-thirds remains severely handicapped, 1 to 2% independent status with gainful employment. 5 to 10, 20% achieve a borderline normal status. Treatment-wise, no cure for autism, and second one is goals of treatment is to improve ability to integrate into society, increase the likelihood of maintaining independent living, and as adult, we motivate them to live normal life in society. Reduction of disruptive behavior. Ideal treatment plan coordinates therapies and intervention that are targeted the core symptom of autism. Educational and behavior intervention. Treatment of choice. Structural classroom training, improve language cognition, decrease maladaptive behaviors, developing social and language skill, family therapy, facilitated communication. Medication is to reduce anxiety, depression, OC symptom, aggression, hyperactivity, and self-injurious behavior. We can give escitalopram, lamotrigine, methylphenidate, amantadine, antipsychotic to reduce the aggression and self-injurious behavior. Asperger's disorder. In 1944, Hans Asperger, an Australian physician, described a syndrome that he named autistic psychopathy, applied to person with normal intelligence who exhibited a qualitative impairment in reciprocal social interaction and behavioral oddities without delay in language development. Unlike autistic disorder, no significant delay in language, cognitive development, or age-appropriate self-help skill. Recent study found that children with Asperger's disorder were more likely to look for social interaction and sought more vigorous to make friends. There are some clinical features. First one is markedly abnormal non-verbal communicative gestures, failure to develop peer relationship, lack of social or emotional reciprocity, impaired ability to express pleasure in other person's happiness. Treatment is mainly supportive. Goals are to promote social behaviors and peer relationships. Self-sufficiency and problem-solving techniques are often helpful for these individuals in social situations and work setting. Now, Rett disorder. In 1965, Andrew Rett, Australian physician, Rett disorder is a progressive condition that has its onset after some months of what appears to be normal development. SE is normal at birth and developmental milestones are unremarkable in early life. Cause of Rett disorder is unknown, likely to have a genetic basis. Complete concordance is in monozygotic twins. Diagnosis and clinical feature. First 5 months after birth, infant have age-appropriate motor skill, a normal SC, and normal growth. Social interaction shows the expected reciprocal quality. 6 to 2 years develop progressive encephalopathy, loss of purposeful hand movement, hand bringing, loss of previous acquired speech, psychomotor retardation, and ataxia. HC growth decelerate and produce microcephaly. All language skills are lost, and both repetitive and expressive, communicative, and social skills seem to plateau. Poor muscle coordination and an apraxic gait with an unsteady and stiff quality develop. Associated features are I think seizure is present in 75% of cases. Disorganized EEG with some epileptic form discharges in almost all children. Irregular respiration with episode of hyperventilation, apnea, and breath holding. Live well for over a decade after the onset of disorder. After 10 years, many patients are in wheelchair bound with muscle wasting, rigidity, and visual no language ability. Patients who live into adulthood remain at cognitive and social level equivalent to that in the first year of life. Treatment again is symptomatic. Physiotherapy for the muscular dystrophy, anticonvulsant treatment is necessary to control the seizure. Behavior therapy along with medication may help control self-injurious behavior. Now, childhood disintegrative disorder. Heller syndrome or disintegrative psychosis, we called it, marked regression in intellectual, social, and language function after at least 2 years of apparently normal development. After the deterioration, the children closely resemble children with autistic disorder. 1/10 as common as autistic disorder, boy to girl ratio is 4 to 8:1. Cause unknown, associated with other neurological conditions, including seizure disorder, tuberous sclerosis, or various metabolic disorders. Onset may be insidious over a month, and for diagnosis, a child must exhibit loss of skill in the two of the following areas: language, social or adaptive behavior, bowel of bladder control, play, motor skill. Abnormality must be present in at least the following categories: reciprocal social interaction, communication skill, and stereotype or restrictive behavior. Course variable, and treatment is same as that of autism. Autism and MMR vaccine. MMR vaccination rates began to drop. MMR vaccine triggering autism was questioned because a temporal link between the two is almost predestined. Both event by design, MMR vaccine or definition autism occur in early childhood. Uh, Wakefield et al. Were guilty of deliberate fraud. They picked and chose data that suited their case. They falsified facts. Implication: parents across the world did not vaccinate their children out of fear of the risk of autism, thereby exposing their children to the risk of disease and the well documented complication related thereafter. There are some references like CTP, synopsis of psychiatry, and other. Thank you.